thank the TASL Organizing Committee to invite me for a talk focused on the trend of HCV-related HCC risk after DAA treatment in Taiwan. Today, the outline of my talk will slide on 4 points. The first one is the risk of de novo HCC with DAAs. The second one is the risk of recurrent HCC with DAAs. The third one is the risk of de novo and recurrent HCC with DAAs in East Asia and Taiwan. And last one is the summary. So the first part is the risk of de novo HCC with DAAs. The reduced risk of HCC occurrence in the era of interferon-based therapies has been established in many studies. The studies from Europe and Canada clearly show that the 10-year accumulated HCC incidence was 5.1% in patients achieving SBR, comparing to 21.8% in those not achieving SBR. That is, the annual incidence of HCC was reduced to 0.5% after SBR by interferon-based therapy, whereas the incidence was about 1 to 4% per year in untreated patients. The studies focused on the risk of HCC occurrence was first demonstrated in 2016 when 1,067 HCV cirrhotic patients who achieved SBR following sulfoxaflor-based DAAs, which showed that the incidence was 0.5% in compensated cirrhosis and 2.61% in decompensated cirrhosis. The annual incidence of HCC was comparable among patients receiving interferon-based or interferon-free therapies in compensated cirrhotic patients. An interesting point to assess the risk of HCC occurrence or recurrence is to know the trend of HCC development in patients with SBR, because the follow-up time is generally longer in HCV patients treated by interferon-based therapies than those treated by interferon-free DAAs. The trend of risk for HCC development will be an important controlling factor when we assess the relative risk of different treatment regimens. For example, if the trend is linear, we can make near-close correct conclusions. However, if the trend is quadratic or inverse quadratic, we may under or overestimate the risk of HCC development. Here, I demonstrated that the trend of HCC occurrence would not be the same when the patient was stratified by age at a cutoff level of 45 or 60 years. The trend would be linear for the age less than 45 years, but the trend tends to be inverse quadratic for age more than 45 years. To solve the potential confounders that may affect the outcome, the use of propensity score matching may be helpful to reach accurate assessment. The study tried to compare the HCC occurrence in patients who achieve SBR by dacaltazepine, azunapravir, or pegylated ribavirin. The current risk of HCC occurrence tend to be higher in DAA groups compared to the PR groups. However, when the authors make propensity score matching by better balancing the confounders between groups, the risks of HCC development were comparable regardless of type of antiviral treatment. This prospective study also tried to assess the risk of HCC occurrence in SBR patients by DAAs or interferon-based treatment. The crude HCC incidence of DAA SBR patients was higher than interferon SBR patients. When the authors used the inverse probability of treatment and sensory to match the groups, no risk difference of HCC occurrence were observed between interferon or DAA-induced SBR. When comparing the HCC occurrence in DAA treatment patients who achieve or not achieve SBR, the VI system, which recruited a sizable number of patients, revealed a beneficial effect of HCC incidence following viral eradication. Of note is the annual incidence was 0.9% in DAA-induced SBR patients, and fell within the 95% confidence interval of HCC occurrence risk in interferon-induced SBR patients. Just as I have previously mentioned, the trend of HCC risk reduction following SBR may not be linear in some subgroups. Here, the study ideally demonstrated the trend of HCC risk reduction among cirrhotics or non-cirrhotic patients who achieve or not achieve SBR by interferon or DAAs. The curves in this subgroup seems very similar between SBR patients by interferon or DAAs, implying that the treatment regimen per se did not affect trend of HCC development. The second part will be focused on the risk of recurrent HCC with DAAs. The concern for the increased risk of HCC recurrence after curative therapy in 58 HCV patients receiving DAAs was first reported from Spain, with 27.6% of patients with outcome shortly after DAA therapies. Furthermore, the recurrent tumors tend to be more aggressive for these patients. Subsequent studies from Italy and the United States of America also revealed that the proportions of HCC development were increased in patients with a prior history of HCCs. While all studies agree that the risk of HCC occurrence is significantly decreased following successful viral eradication by DAAs, some studies show that the risk of HCC recurrence following DAA-induced SBR is not decreased or even increased among patients with complete ablation of HCC. The discrepancies for patients with or without a prior history of HCC remain elusive. The proposed mechanisms are reduced immune surveillance following DAA-induced viral suppression or the direct neoplastic defect of DAAs. However, a prospective French study showed that the survival rate of HCC recurrence from 3 cohorts were similar among HCV patients receiving DAAs or interferon-based treatment. The criticism for the Spanish study showed that if we stratify the time-dependent exposure factor between HCC treatment and the last HCC imaging assessment, the accumulated tumor recurrence differs, implying that the earlier imaging assessment might underestimate the naturally late HCC recurrence. The other criticism for the Spanish studies also showed that if we stratify the time-dependent exposure factor between HCC treatment and the time of DAA treatment, the accumulated tumor recurrence also differs, implying early DAA treatment may include more patients with natural HCC recurrence. High HCC recurrence among patients with earlier imaging assessment or DAA treatment might miss some non-characterized hepatic lesions which evolve to HCC. Therefore, the DAA treatment may be the confounding factors which erroneously attribute to the trigger factors for HCC recurrence. To solve this uncertainty, the North American collaborative cohort, which recruited a sizable number of patients with HCC curative therapies and adopt a time-dependent incidence estimations for patients with or without DAA treatment, taking a landmark analysis of 90 days after HCC complete remission to avoid early tumor recurrence due to incomplete treatment or evolved non-characterized tumors. The studies revealed that DAA treatment did not increase the risk of HCC recurrence, and the time interval set at 6 months of HCC complete remission did not affect HCC recurrence. The third part would be the risk of de novo and recurrent HCC with DAAs in East Asia and Taiwan. Regarding the risk of HCC occurrence, a recent collaborative study in East Asia, which compared the accumulated incidence of HCC development in prior HCC naive history patients who achieve or fail to achieve SBR by using the propensity score matching, which balanced the potential confounders between groups. The risk of SCC occurrence in patients with SBR was significantly lower than those who did not achieve SBR. Accordingly, the trend of SCC occurrence were also different when the study focused on the high-risk group of cirrhotic patients. By multivariate analysis, the SBR is the only factor to predict decreased SCC occurrence in East Asia HCV patients. Accordingly, the trend of SCC occurrence were also different when the studies focused on the high-risk group of cirrhotic patients. By multivariate analysis, the SBR was the only factor to predict decreased SCC occurrence for East Asians. In Taiwan, 3 studies have been published, all focusing on the SCC recurrence following DAA treatment. The first one was from Chang'an Memorial Hospital, which enrolled 82, 80, and 160 patients receiving DAAs, interferon, or age-sex match untreated controls. Patients who received DAAs had a lower early recurrence-free survival compared to interferon groups, either by crude rate or propensity score matching adjusted analysis. However, patients who received DAA treatment had a lower SCC recurrence rate compared to untreated group. This study implies that patients with DAAs had a high risk of early tumor recurrence compared to interferon group, but the viral eradication may improve the tumor recurrence outcomes. The second study was from Taipei Veterans General Hospital and Jiayi Christian Hospital, which assessed the SBR rates of DAA treatment in 199 patients with a history of SCC from BCLC stage 0 to C. The SBR were high, ranged from 95 to 97%, except for patients with BCLC stage C SCC. Among patients with baseline BCLC stage 0 or A who achieved curative therapy, the recurrence-free survival were similar among interferon and DAA treatment groups, either from the time point of antiviral treatment or curative HCC treatment. The study was in contrast with the study from Chang'an Memorial Hospital, in which the DAA group had less favorable outcomes. The third study was from McKay Memorial Hospital, which aimed to assess the clinical outcomes of 107 patients with SCC from BCLC stage 0 to C who received DAAs who would not receive antiviral treatment. Patients received DAAs had significant survival benefit over those without treatment, irrespective of tumor stages. However, patients who underwent curative HCC treatment and who received DAA treatment did not have a recurrence-free survival benefit over those who did not receive treatment. The study was also in contrast with the study from Chang'an Memorial Hospital, where the recurrence-free survival in DAA treatment patients had significant benefits. The discrepancies among the 3 studies may be reasoned by the methodology adopted and a small sample size which might make the final conclusion uncertain. So the last part will be the summary. Despite there exist controversies for the risk of SCC occurrence or recurrence following DAAs, the level of evidence will be strengthened by using the meta-analysis. It is studies which reviewed 41 studies analyzing nearly 40,000 participants. It indicated that the follow-up time and age were not well balanced between patients with DAA or interferon. Therefore, the study tried to adjust the important confounders to lessen the biased conclusion. By adjusting the average years of follow-up and age, the risk of SCC occurrence or recurrence in patients with DAAS were comparable to those with interferon treatment. To this end, these studies confirm that DAA per se may not increase the risk of SCC occurrence or recurrence. In summary, the SCC incidence with DAAS seems to be higher than with interferon, but the trend may be due to the higher proportion of more advanced HCV patients by DAAS. Therefore, we should still treat patients with cirrhosis, but the SCC surveillance after SBR is critical. With regard to SCC recurrence, the results are somewhat conflicting. The early SCC recurrence in patients treated by DAAS is still of clinical relevance, but probably might reflect the incompleted cure SCC or the existence of non-characterized nodules. The long-term recurrence seems to be less of an issue. Furthermore, it is important to report the instance rather than the percentage of recurrence to avoid erroneous interpretations. So it is still practical to discuss with the patient about the benefit and potential risk of SCC recurrence after DAAS to improve the health-related outcome in these patients. Thank you for your attention.